program of Perry Worldhouse, the University of Pennsylvania's Global Affairs think tank. I hope everyone is safe and healthy. My name is Michael Horowitz. I'm the director of Perry Worldhouse and a professor of political science. I'm honored to have Dr. David Heymann with us today. He is currently professor of infectious disease epidemiology at the London School of Hygiene and tropical medicine. He is a distinguished leader in the area of global public health. He's the head and senior fellow of the Center for Global Health Security at Chatham House, chairman of Public Health England for the United Kingdom. Previously, he was the World Health Organization's Assistant Director General for Health Security and Environment and representative of the Director General for Polio Eradication. From 1998 to 2003, he was executive director of the World Health Organization's Communicable Disease Cluster, during which he headed the global response to SARS. Before that, he worked for 13 years as a medical epidemiologist in sub-Saharan Africa on assignment from the US CDC. He's won any number of public health awards and has had a long career in dealing with just the sort of thing that we're talking about today. So Dr. Heymann, thanks so much for joining us at Perry Worldhouse. And why don't we start off with one of the questions everyone wants to know about. What sort of responses have different countries had to the challenge of COVID-19 and how are we doing?
Well, thanks, Michael. Thanks for the kind introduction. Yeah, what are different countries doing? Well, it depends on where you live, really. In Asia, countries were ready for this outbreak. They had had SARS outbreaks previously. They had had MERS corona outbreaks previously, and they were ready. They had excess capacity in their hospitals. They had ventilators in their hospitals ready to use. And they began rapidly to stop outbreaks when they occurred. So the minute they saw cases coming in from China, they tried to interrupt transmission and stop community spread. So Asian countries have continued on that course, but they've done occasional circuit breaker activities, which is what they like to call them. For example, in Hong Kong, when Chinese students began to come back a couple of weeks ago after school holiday, they brought infection with them, and Hong Kong shut down the amusement area in the city. Singapore shut down its public school system when it found that people were carrying the disease home to their parents, and then they open again after that occurs. And all of these countries, whether it's Singapore, Hong Kong, whether it's South Korea or Taiwan or Vietnam, they've been able to keep that reproductive number less than 1. The reproductive number is the number of people who are infected by each infected person. And if you can keep that number below 1, you avoid a rapid increase in cases. In Europe, the response was entirely different. Germany was one of the only countries, Germany and the UK, that began with outbreak containment activities. When they first identified clusters of patients, they tried to interrupt transmission. But then there was a massive outbreak, as you'll remember, in Italy.
Right.
And that outbreak overwhelmed hospital beds in Italy. And there were many, many deaths because people just couldn't get to hospitals. So European political leaders, rather than listening to the epidemiological leaders who would have continued to say, continue containing the outbreaks through outbreak containment, contact tracing, and isolation of patients, they began to just lock down like China did. And so they locked down entire economies. As a result, they have by now flattened the curve of people, and they have in many countries, the reproductive number under 1. But those countries have paid a severe economic penalty, as you know. And the only country in Europe that hasn't done that is Sweden, which decided they would let the outbreak occur and try to contain as best they could, but put the responsibility on the citizens to physically distance. They closed down social gatherings for social distancing, and they have made a few other recommendations. But they've seen the disease enter. All countries, though, in Europe failed to protect the elderly, especially in the elderly care homes. And that's sort of the picture in North America and the United States as well. It's been a state activity, and states in some instances have done very well in protecting the elderly, in others they haven't. So it's a mixed bag of interventions, if you would, and it's still not possible to say who was right and who was wrong, but we'll see as time goes on.
So you think it's too early to tell, for example, whether Sweden's sort of unique approach, as you're laying it out, whether that was relatively more or less successful?
Yeah, it's too early to really say anything about that. The Swedish officials say that they believe about 24% of the population in Stockholm has had infection, mainly mild infection, but
Wow.
they're not certain yet. So they've seen it come in, whereas other countries have levels of about 5 to 6 to 7% of population in major cities infected.
Right. I feel like I read an article last week about Spain and antibody testing in Spain that suggested that it seemed like the spread had actually been lower than some people were almost hoping for at this point, given where Spain was.
That's right. In fact, anyone who says that this disease spreads as does influenza is wrong, because it doesn't. It doesn't spread quite so easily, and you can stop outbreaks when they occur by isolating patients and by contact tracing, and then making sure that you follow up on the contacts. So it's been very successful in many countries, and I think Spain thinks they have about 12% of population, maybe in Madrid, that's been infected.
So let's take a step back, because you mentioned influenza and you mentioned SARS. And so can you, our listeners are people, all around the world, from both inside and outside, the Penn community, the global policy community. How, in your view, does coronavirus compare to some of these diseases of the past? And what can we learn from that? To SARS, to the Great Influenza, et cetera.
Well, the Great Influenza back in 1917, 1918 occurred before there were antibiotics in the world. And so it's thought that
Right.
many people died from bacterial infections on top of the viral influenza. So it's really one landmark with very high mortality, but it's probably not the best way to benchmark today. Today, there have been 3 pandemics of influenza since then, and they've had moderate mortality, but nothing compared to the mortality in 1917-18. So if you then move ahead to the SARS outbreak in 2003, that outbreak occurred, it began probably about the same time of year as did the current COVID virus outbreak. But then this was a virus which reproduced low in the respiratory system, whereas the current coronavirus produces upper respiratory system. So it's easier for people to cough it and to breathe it out into the air in droplets than it was for SARS. So what we're seeing is a disease that spreads easier than SARS, and it probably can't be contained as was SARS when SARS was eliminated from human populations.
So maybe one thing you might be able to help us understand is there's a lot of controversy right now surrounding the World Health Organization. And my bet is that most Americans prior to this probably couldn't tell you a whole lot about the World Health Organization, and they might not be able to now. So can you educate us a little bit to start? What is the role of the World Health Organization in dealing with a pandemic like this, and why is there this controversy?
Well, the World Health Organization, like all other UN organizations, is a political organization. At the top, there's a political leader who's elected by 194 member countries. So that, of essence, makes it a political decision who the Director General is. But underneath that, there's a whole group of technical experts within the organization, and they're the ones who are showing the real value of the organization now, as they always have done. It's because this technical group of people is able to network with countries around the world, including those that are having geopolitical tension, China and the US, able to get information from them and from other countries such as Iran, South Korea, wherever you want to get information, WHO can get it. And by getting that information and then reviewing it by several different advisory groups, they're able to make some recommendations about what needs to be done. And these recommendations are in real time. I actually chair one of the advisory groups to the emergencies program at WHO. We meet twice a week, and twice a week we have updates from countries around the world as to what's going on, what might be working, and what isn't working. So WHO is this political organization, but it has a technical arm which works technically and provides the world with information that they need in order to better deal with infectious diseases.
So without betraying any confidences, of course, one of the controversies, I would say, surrounding the World Health Organization has involved the I would say the perspective of the United States, maybe perspective of the American government, the accuracy of the information that we're getting from many autocratic countries around the world about the spread of the virus, especially China. But if you look at, sort of the broad commentary, not limited to China, could you maybe, if you're getting updates, twice a week, again, without betraying any, confidences, of course, what could you tell us about the kind of data maybe that people send in or abstracting out, how we should think about the different kinds of data that different countries send and how accurate it might be?
Well, right now, we're trying to understand three different issues.
Okay.
We're trying to understand whether transmission occurs in people who never develop symptoms. We're trying to understand the immune response to the virus and whether that immune response protects, and if it does protect, for how long. And we're also trying to understand which tests are best used in determining the antibody status of people who have been infected. For that, we've questioned people. In fact, on Friday, we had representatives from Russia and from Mongolia providing us information. The week before, we had representatives from China who have the most information because they've had the longest ongoing outbreak. We had information from the US, from Singapore, from any country that WHO requests information, they get it. Now, all that I can say is the information is as valid as that which countries report. And whatever they're reporting, it's given us enough information so that we can make recommendations which have so far been valid. So, it's a political organization, but technically it operates quite well. And that's where I like to keep my actions at the technical level, rather than getting too involved in the politics at the top.
Sure. I mean, as we turn to the Q&A, I think you will find some of the people will want to know about the politics of it. And so hopefully you can inform us on that as well. Let me turn to some. We've got questions flying in from the audience. We've got over 200 people online watching right now, and one question says, I appreciate what you were saying about what should have happened back in February. I think this is focused on the U.S. But we've had community spread in the U.S. for months. Cases are increasing, although linearly rather than exponentially. What's the next step, you say from an American perspective, since I think there's a lot of fear in the United States that the US might be reopening too quickly, and what the consequences might be for the spread of the virus?
The basis of successful unlocking is understanding by the people, by the population, how they can protect themselves and protect others. And it's very simple messaging, and it's very effective. To protect yourself, you must maintain a physical distance from others, suspecting that they may be sick or infected. And you must wash your hands frequently, especially if you touch surfaces where people who may have been sick have been coughing or sneezing and depositing droplets on those spaces, or even speaking. So that's how you can protect yourself. To protect others, if you're sick, you should self-isolate, even if you don't know if you have this disease. At the same time, if you can't physical distance from family members or from the elderly in your household and you're sick, you should wear a mask. And for people who are working in homes for the elderly, in the case that they might be infected and could transmit when they speak to a patient, they should always be wearing a mask, because that mask protects droplets from going from your nose or your mouth to patients. The reason wearing a mask to protect yourself isn't effective is because the eyes are exposed, and the eyes are also an entry point for the droplets that could cause infection. So if people understand how they can protect themselves and protect others, that's already a major step forward, and people don't have to fear so much about when unlocking does occur. Trusting that the government has in place, and this will be state governments in the US, a response mechanism that if there are outbreaks, they can first of all detect them rapidly, then they can isolate patients, do the contact tracing and testing necessary to stop outbreaks.
So here's one of those technical questions from one of our guests who asks about the question of immunity and what different scenarios of immunity look like. And as people, even lay people, like I'm a social scientist, and I know nothing about biology or nothing about epidemiology, and what do these different scenarios look like? There seems to be a lot of disagreement almost in some of the early scientific papers about whether having coronavirus gives you partial immunity, full immunity, and for how long.
Well, whenever there's a new infection that occurs, such as this coronavirus, you look to the past history of coronavirus infections. And as you'll know, there are 4 different coronaviruses which are carried in humans regularly.
Okay.
Those have emerged from animals in the past. They've been very mild viruses, and they cause the common cold in humans. And they cause colds every winter season in the Northern Hemisphere. We know for a fact from those coronaviruses that they do produce limited immunity. Sometimes you can be immune from a coronavirus infection, but the next year you're again infected by that same virus. So if they do create immunity, it's not long lasting. We know that SARS created some immunity. We don't know how long it really lasted. We know that MERS coronavirus also causes some immunity. So we assume that this virus also causes some immunity. We just don't know whether that immunity will protect against reinfection. And we don't know whether or not a vaccine can develop which will provide immunity that will prevent future infections. So we're right at the beginning of learning a lot about this virus, and we'll learn a lot from studies that are going on now in monkeys that simulate the disease that humans have.
So here, let me switch from a technical question to a policy question that that somebody asked about what the distance might look like or potential conflicts between what we need to do medically from a contact tracing perspective, and that it seems to be more effective when it's centralized, sort of with geolocation, but what that means for privacy and surveillance. And you have different kinds of approaches that are floated. You have the sort of Google Apple app idea. I mean, who would have ever thought Google and Apple would be working together on something? You have the Swiss-led group, DP3T. You know, what route would you prefer for how we balance the need to contact trace with the challenge from increased challenges, you know, sort of threats to privacy from growing surveillance?
Well, these apps that have been developed have been used in China. They've been used in Singapore, in Hong Kong, in South Korea. They're also being used in Germany. Apps are very useful in contact tracing because what they do is they tell you if you've been near someone who was infected so that you can then report yourself to an agency which can test you. That's the way the voluntary apps work. They don't always work that way. Some countries require that they proactively follow up and get the name and contact information of the contacts and of patients. But in most Western countries, it's voluntary. And myself, I would certainly subscribe to it, knowing that if I put my name into it, I would be notified if somebody else who was sick had put their name in and said that they were infected. So I think they can be very useful. I would get a message from my phone operator or from my app telling me to call this number, say I might have been exposed, and get a test or tell me what to do. So I think we can't ignore the importance and the strength of current technologies, and we have to work out how they work best and what's best for each person. You know, it's really, this disease is a personal perception as well as a government perception. And if people feel that they want to volunteer their names into an app to understand if they've been exposed, they're able to do that in countries that have them. And if they don't want to, they can't be forced to do that. So I think new tools are very good. We'll learn how to use them. And I think phone apps in particular with GPS positioning are very interesting.
So does an organization like the World Health Organization have a role to play in some of those choices, or will those inevitably be made on a state-by-state basis? You know, we've heard a bit about the role that international institutions can play in coordinating vaccine development, even though it seems like the US is sitting on the sidelines of that particular effort right now. But what's the role of the World Health Organization in tackling some of these more, you know, specific challenges?
Well, the World Health Organization works very much like CDC in Atlanta, the Center for Disease Control. For each group of diseases or disease, they have an advisory group. And that advisory group reviews peer-reviewed articles, it reviews other information, and it comes to a consensus on best practice, what best practice is, and it develops guidelines that are then provided to countries as a standard. countries then can use those guidelines then to adapt them to their own needs. So in the case of a phone app, WHO would say what best practice is, what the ethical considerations are, what the privacy considerations are. It would put the pros and cons, and then it would be up to countries to adapt what they feel is most useful in their own context. Some countries, developing countries, depend on WHO and very seldom even doubt a guideline. They just use it directly. But fortunately, more and more that's changing so that countries are really adapting them to their own context.
So let me follow up with there's a I think a good follow up to that in the Q&A, and people keep the questions coming. This is great. That asks about how COVID-19 is affecting South America and Africa. Most of the discussion that we've had surrounds Western Europe, North America, East Asia. What's happening in the global South, and in the rest of the world.
Well, in sub-Saharan Africa, it's entered into the country mainly through Europeans coming back from their Christmas holidays or holidays. In fact, it didn't happen so much when the Chinese came in back after their holidays in the beginning of the year. It's entered with Europeans mainly into South Africa and other African countries. Now countries are dealing with the outbreaks in those countries where they're occurring, but they haven't caused this high burden of hospitalization, and they haven't caused these high level of deaths in the elderly. But you have to think about African populations. The median age in Africa, surprisingly, is only 19 years. So it's a very, very low age population. There are many elderly people, but the median, that is halfway point between ages, is 19 years of age. So we see that Africa has a very young population, and we know that young populations are not affected in the same way as our other cultures. We also understand that there are fewer comorbidities that are the major risk factor in our countries for sickness and death, including obesity, including diabetes, including hypertension, including many diseases of lifestyle, which possibly don't exist in some of the African populations. So nobody knows for sure whether this will begin to explode within Africa, but now it's increasing at a fairly steady rate, but certainly not the same extent as it did in China, in South Asia, or in the rest of the world. In Latin America, we're seeing that it is increasing. In fact, Mexico, just south of the US, is having a great increase right now. And as you know, obesity is a major problem in Mexico. They've had attacks on sugary drinks and a whole series of things to try to deal with these issues. And in Mexico, they are seeing increasing cases and increasing mortality, as in the rest of Latin America. So the jury is still out as to what will happen. We can hope that it won't be as great as in other countries, but we just don't know yet.
So to ask a follow-up from that, somebody in the Q&A currently lives in Ghana and asked about says that despite the implementations of lockdowns, they're concerned about the spread of infections from urban areas to rural areas as urban residents essentially flee lockdowns for rural areas. What do you think we can do to help with contact tracing in that kind of a situation? And do you think that there are lessons learned from the 2014 Ebola outbreak in West Africa that might be useful?
Yeah, well, I think it's a very good question. And, I spent 13 years in sub-Saharan Africa, and I started with the first Ebola outbreak. And I went from there to many other outbreaks with Jean-Jacques Moyembe, who was the first virologist and medical doctor to ever really see an Ebola infection in August of 1976. When Moyembe goes into rural areas where there are outbreaks, his first stop is not the hospital. It's the district commissioner. And he asked the district commissioner to pull together that evening or the next day all the traditional chiefs, the paramount chiefs, all the different culture, all the different social structures within the communities, the people who are respected, the elders. And the next day he meets with the elders and he speaks to them in their language in ways that they will understand, telling them about Ebola and how those communities can help to prevent the spread further. And he uses what some people would call demeaning terminology, but in his case, it's terminology he knows the chiefs will understand. And he says, number one, people who are sick are filled with evil spirits. and those evil spirits are making them ill by trying to get out. And number two, if you touch their bodies, either dead or alive, those evil spirits will come to you and you will become sick and die. So what you need to do is help your community members stay away from those people who are sick, physically distance, and dead bodies, and at the same time, work with the government teams when they come in to stop the outbreak. And that's been successful in over 12 outbreaks in DRC. The most recent one, as you know, occurred in an area with civil disturbance, and
Right.
that's been a difficult one because there's not been community trust. But for our colleague from Ghana, I think that the best thing is to let communities understand that they have the power themselves to do this and give them the right messages. Physical distancing in their terminology, social distancing in their terminology, no mass gatherings, and at the same time, hand washing, even if there's no soap, just in water, physically removing the virus if possible from the hands.
So if I could propose to continue to quiz you on the rest of the world, two different people have asked questions saying, hey, what about India? And, India's a huge country, a rising power, a democracy, but, in a very different part of the world. How is Modi's lockdown going, especially in a country that diverse?
Well, it's interesting, and it depends on states, clearly, how the response is going. It's been quite effective in Kerala in the south, very effective. In fact, they've kept the reproductive number very low. The Minister of Health of India spoke with our group a week ago, and he said that he felt that the lockdown had been very successful in preventing a massive explosion of cases, but they are still on an upward trend in most parts of India, but they haven't seen yet the difficulties with the comorbidities, which they have in India, but they haven't seen difficulties yet in their populations with comorbidities or their elderly. But it's still early again in their epidemic as well, and so time will tell. But the minister felt that the lockdowns had been effective, and they've begun to release them in some places, as you know. There's a great concern. There's a great, sorry, Michael. I was just going to say, as a sociologist, you'll appreciate the fact that there's great concern that these lockdowns are causing very difficult situations for many people who are just on the border of being able to survive financially. And also the fact that many of them do have illness, which is maybe they're not able to reach the health facilities because they're crowded with other patients or they're not open at present. So very difficult for many different groups of population.
So I want to shift from India back to the United States. I was wondering if you could tell us a little bit about, I guess to start, there are a bunch of people have asked questions about the America's relationship with the World Health Organization. And so to start, the U.S. at present has been a significant funder of the World Health Organization. What does America's funding go toward now?
Well, the U.S. funding goes towards many different activities at WHO. The U.S. pays what's called an assessment, which is the assessment that all countries of WHO must pay to be a member. This assessment is based on a formula which was developed based on GDPs after World War II, but has been modified slightly. And so I think to the regular budget of WHO, that is the budget which is assessed contributions, the US pays about 15 to 17%. Then the US pays extra funding, extra budgetary funding for activities of interest to the US. For example, it's a major contributor to polio eradication. It provides each year tremendous amounts of money, millions of dollars, over $75 million for polio eradication activities. CDC also provides technical advisors to WHO. I myself was at WHO as a technical advisor seconded from the CDC to provide US expertise to the organization. Right now, there are at least 5 or 6 technical people from CDC assigned to WHO in various programs where they're providing support at no cost to WHO. So the US contribution is many. It's financial, it's technical, and it's assessed, and it's voluntary. So if the US does stop providing funding, there are many ways that it could do that. And each of those ways would harm in a different way. Suppose the US stopped giving extra budgetary funds to polio eradication, we might see polio, which is almost gone from the world, increase dramatically. So hopefully the US will not stop its contributions to WHO. And, as a US citizen, I would be very disappointed if that happens.
Could you maybe say a little bit more about that? There were some reports that emerged a few days ago suggesting that the U.S. might not actually cut all of its funding, but then a report last night said that Trump is thinking about proceeding. What sort of message will it send to the scientific community if the U.S. withdraws its support for the World Health or financial support for the World Health Organization?
Well, what I hear from my colleagues in Europe and in Asia is that it's one of disappointment that the US, which was always so generous in providing some types of global leadership and finances, is now withdrawing. And it really struck home to me about 4 weeks ago when, in a mentoring program that I participate in from the London School of Hygiene and Tropical Medicine, I met with one of my mentees, one of the people who I mentor, who is a public health official in Mongolia. And she said to me, she said, we don't know what to do. We used to look to Europe and the US for guidance as to how to deal with outbreaks such as this. And now we've seen that they've failed, and we have to go to Asia and to the other places where we've never gone before. And she said, it's quite disappointing to us not to be able to look up again to Europe and the US in this terrible outbreak. That's what she said. And I think many other people feel the same. So there's a real loss of leadership from the US. And that's really a shame in a world where we're so interconnected. We should all be working very closely together. And that will apply also to if and when we develop a vaccine or drugs that are effective in treating this infection.
So one might say that I think some people would argue that the American concern with the World Health Organization, there's a piece of that that's about China, but there's a piece of that that reflects why don't we say some of the broader anti-science sentiment that you've seen, bubbling up in parts of societies in the United States, in the West, as well as elsewhere. Is this unprecedented in some ways in dealing in happening in the midst of a pandemic, or is that sort of skepticism of science something that somebody like you is used to because it's just sort of part of something you've dealt with in your whole career?
Well, I started at CDC in 1976, a long time ago. And at that time, it was purely a science organization, marginalized in Atlanta, not much known about it in Washington, in fact. And over the years, it's become very important nationally and globally. And it's also been politicized as well, in that the director is now named by the President of the United States. So it's become an organization which was very important and still is extremely important technically around the US and around the world in providing guidance. But a group of colleagues of mine, all of whom are now retired from CDC, is communicating regularly. And we're very disappointed that CDC does have the knowledge and the skills and is providing the information, but many times it's ignored and not being used. And so in essence, CDC is not playing the role in this outbreak that it has in many other outbreaks in the past, either nationally or globally.
Could you maybe say a little bit more about that? And I say this as a proud graduate of Emory University, and remember I was about to say fondest memory, but it's not exactly a fond memory. Like driving around sort of back areas by campus, and sort of some friends and I stumbled toward a CDC gate where there were people with guns. We were like, oh dear God, it's time to turn around. Why, the CDC is that's the place. To the extent Americans know things about public health, what they know is, the CDC, they're the ones who will figure out what to do. What's going on?
That's the question we all ask, Michael, and nobody really understands for sure what is going on. And hopefully CDC will regain its voice and be able to provide the guidance that Americans want and need, and not have the guidelines that it prepares just pushed aside for other guidelines when they're not convenient.
So we've got some questions now in the coming in about preparedness for pandemics. Do you're an expert on this, and one way of thinking about it is that, we're never really going to be ready when these things happen. Another is that, we should be taking lessons learned. Of course, we should be taking lessons learned and trying to get better, and prepare. How would you assess the reaction essentially to the initial outbreak, whether in China or elsewhere? Was preparedness sort of at the level that it should have been?
Well, it clearly doesn't seem it was outside of Asia. If you look at a place like Singapore, though, they have built after the SARS outbreak over 300 beds in their public hospital, in addition to many beds in private hospitals that can take patients who need to be isolated. And each one of those rooms has a dialysis unit as well as a ventilator.
Wow.
So these countries have really taken it seriously. In South Korea, it's the same, in excess of beds. Countries in Europe and North America had contingency plans and have been able to rapidly establish hospitals in conference centers or in various places. And so they were prepared to a certain extent. But clearly they had a period of time when they could have gotten better prepared, and some didn't. And WHO put out on its outbreak list on the 5th of January that there was an outbreak of respiratory disease occurring in China, which had not yet been identified. And so any epidemiologist who reads that, and this information on the outbreak list goes to 194 countries, to the focal point of the international health regulations in those countries. So every country was notified on the 5th of January about this outbreak. It didn't say it was transmitting person to person. It didn't say it wasn't. It just talked about an outbreak. Then when our group, the group that I chair, reviewed this information in a week, we recommended to the Director General, along with other groups, that he convene an emergency committee meeting, which he did on the 22nd, I think, of January. That committee was divided as to whether or not there was enough evidence to call it a public health emergency of international concern. But even so, countries already should have been thinking, what should we be doing? Should we be preparing? This is something big. And the committee called for more information, and 2 weeks later got that committee. And the committee then met again. I'm not on that committee, it's a different committee, but they met again and they said, this is a public health emergency of international concern. By that time, China had stopped all travel outside of the area where the outbreak was occurring, giving countries the opportunity, maybe a very short window of opportunity, to really get ready. So I would just leave it up to the citizens in countries around the world to make their own determination of whether their country was ready or not.
So we've got a couple questions coming in. I want to dive back into maybe the details here and thinking about coronavirus. And we have one question that asks, actually, and frankly, I don't know, I'm kind of curious about this. I'm wearing contacts now. I could be wearing my glasses. Given the point you made about eyes and infections, should we all be wearing eye protection when we go out?
Well, if you want to be like the health workers, yes, but then you also have to wear a gown that covers your clothing and wear gloves and be in a full personal protective equipment if you want to walk out and be protecting yourself. Otherwise, there are too many ways that you can protect yourself. And that's why in the US, for example, they're recommending to pull a scarf up over your nose or mouth so that you don't cough or spit on people when you're speaking, when you're out in public. And in places in Europe, they're recommending in tubes, I think also in the subway in New York, they're recommending wear a mask covering your nose and your mouth when you're in the subway cars in order to prevent transmission of infection to others, not to protect yourself.
So a follow-up also on the virus specifically, and I wonder about this sometimes, and every article you read, it seems like there are more symptoms associated with coronavirus, to the point where it seems like anything you have seems like it could be a symptom of coronavirus. And on the one hand, I guess from the perspective of getting people to get tested, that's not necessarily bad. On the other hand, I mean, you're like, oh no, like I have my seasonal allergies. Do I have coronavirus? But to be, I mean, whatever. This is a serious issue. I mean, the serious question here is, why do you think, or what do you think is scientific knowledge is right now about why the virus has had such a wide range of unexpected effects?
Well, again,
and is there any information of what the potential for maybe after effects of this might be, given just how broad it seems like the symptoms are?
Well, this is a new virus to humans, and so no human has protection against this virus. They've never experienced it before. Their immune system has never encountered it. And so, as with all new diseases, one of the first things you want to do is establish a definition of what you think a case looks like. And so that was done early on, and it was fever, it was cough, it was pneumonia, various things. Then, as the diagnostic tests became available, it was also confirmation with a diagnostic test, but that only picks up the sick, the people who fit that definition. And what we know now is that there are over 85% of all infections appear to be very mild, like a common cold or even less mild. So that people who may have had very mild muscle aches but didn't really think much of it may in fact have had an infection, which they dealt with very easily. So I would expect that what's called the natural history of infection, the signs and symptoms from the time humans are infected to the time they get sick and eventually get better or die, will be fully understood within the next months. But until then, we'll just have to count on research. Yeah.
So let me ask a more specific and very parochial version of that question. As the parent of a toddler, of course, there seems to be a number of different sort of studies and suggestions and insights about the effect of coronavirus on children. At first, the thought was doesn't affect children. And now it's like, well, maybe sometimes it does. Oh, and when it does, there's this, horrible immune reaction that can inflame everything and be disastrous. What's your sense of what the state of the art is right now and our understanding of the effect of coronavirus on children? Is this a lot of impact, both, obviously for parents, as well as for thinking about questions like daycares and schools and when things might reopen?
Well, this is a virus that nobody wants to be infected with. And we don't understand all what happens in children. We do know that there is this syndrome, Kawasaki syndrome, which is inflammation of the arteries, and that's a very serious illness in children. And right now there's an attempt to better understand if this is always related with, or are we just picking up more of it because we're looking for it, or is it really associated with COVID-19, which is what's expected, what's anticipated. So yes, there are some serious manifestations in all ages of population. I think I saw the statistics yesterday from UK, where of 122 people, only seven had no comorbidities or no risk factors. And so, there are people who have no known risk factors, including children, who then get a serious illness.
So going from details, back up to the World Health Organization, a couple different people have asked questions about the way that the World Health Organization vets information, and that the process that you've described is very much one where countries are sending the World Health Organization information. How do you vet that? Decide what's legitimate or not legitimate, and integrate that with with your understanding of the literature to try to make recommendations?
Well, what's most important is peer-reviewed articles, manuscripts, and there are many, many peer-reviewed publications on this pandemic. And in fact, all major medical journals are not only providing rapid peer review. I review at least 3 articles a week, but in addition, they put that article in front of their paywall so that anybody can have access. Unprecedented amounts of information. And WHO uses that information, but they also then have specific requests to countries, and they get that information from countries. Nobody can say whether or not it's 100% valid or not. That's not possible. We think it is, we hope it is, but a country reports what it wants to report. And so we just have to depend on the goodwill of countries to report what we feel they should be reporting. And myself, I believe that all countries do report as accurately as they're able to. And we're beginning to see China reporting things that they didn't report before because they're learning that they do have people who have asymptomatic infection. They didn't understand that before, early on in the outbreak. And so they are seeing transmission occurring even after these serious lockdowns, but not at a high level of transmission.
So what I want to shift to asking about, in some ways, might be the third rail of some of the politics of the World Health Organization right now, and that's Taiwan. In that there's been a lot of discussion in part in the national security world that I live in, as well as in the sort of public health world about Taiwan's success at controlling the spread of the virus, but it obviously has a very tense relationship with, it looks like there's a tense relationship between Taiwan and the World Health Organization, given the politics of the region. So could you maybe tell us a little bit, but we see the headlines, what's your sense of what actually is going on and how we should think about that?
Well, each year Taiwan attempts to join the UN system, and each year they're refused entry. And that occurs because at one time, as you may remember, Taiwan was a member of the UN, and then China replaced Taiwan as a member, and China decided that they would not permit Taiwan to enter. That was their right not to permit that. So that was an agreement. I don't know how that was made. You'll know better being in the political science area than I. But that was an agreement which was made and continues. And each year, Taiwan attempts to get in. And when there are outbreaks many times, it feels that they're not getting the information they need. During the SARS outbreak, they felt they weren't getting the information needed. And so the Director General at that time, Dr. Brundtland, spoke with the Chinese ambassador in Geneva, and she said, we would like to put someone in Taiwan as a link between WHO and Taiwan so that they can get the information they feel they need, and will have a liaison with WHO. They agreed, that person was provided, but Taiwan continued to say that they didn't have enough support. I'm not saying against or in favor of Taiwan. I'm just saying that this is a political issue, and I wouldn't be able to deal with it. And I think it's every year it comes up at the World Health Assembly. I think the World Health Assembly is one of the first UN General Assemblies during the year. And so that's the first time that they make their application to become a member of the UN system. And, it's one of these events that the technical people want to collaborate with Taiwan and do. Taiwan has access to all information that every other country does, but there's a political element that the technical people are not good at dealing with. And so that goes to the World Health Assembly, which is political.
So let's go from China and Taiwan. We've had a question from somebody in Ghana. We'll go very local, near right down Philadelphia to the Jersey Shore. And the question is that the governor of New Jersey has talked about trusting science and instituted pretty strict restrictions, but it seems sort of convenient that the beaches are now opening up with Memorial Day approaching. How do you think? How would you? If you were in the area, and near the Jersey Shore, would you go to the beach this weekend? Why or why not?
Well, Michael, I think that's a personal decision, really. And that's why I say people have to be empowered to make that decision. They have to know how to protect themselves and how to protect others. I myself would make the precautions I felt necessary. First of all, I would make my own risk assessment. I wouldn't count on any government to make a risk assessment for me. I would make my own risk assessment, and I would decide based on that. If I felt it was safe to go, if I felt I could physically distance, if I could avoid going into restaurants on the boardwalk or wherever people would be going, then yes, I would say I would go. If I felt I couldn't socially and physically distance, and if I felt that I had to go into restaurants where people would be closer together than I felt comfortable, I wouldn't do it. So, it's always easy to say, well, the government's doing this or the government's doing that. But we as individuals must assume our own public health, and we must take our own risk assessment and make our own decisions based on what we understand. And I hope you and I are able to give those people that, Michael, today, so that they can make their own risk assessment and decisions.
So here's let me ask a little bit of a public policy question, understanding that your point about individual choice, and that's we're about to hit Memorial Day in the summer in the United States as things are going to get really warm, and traditionally one of the especially maybe lower income communities that have less access to things like air conditioning. How do we how should, from a public policy perspective, cities especially balance the need for people to go outside for public health reasons with the need to socially distance?
Well, certainly people should, when the government opens up the parks and opens up public spaces, should be permitted to go there if they feel comfortable, walk in those places as long as they physically distance, and especially paying attention to the elderly. And there's something very interesting which has happened in Gibraltar, which has been able to control this infection very well. You know,
Interesting.
Gibraltar's on a rock, and it's right on the border with Spain, where there were many,
It's the
many
rock.
It is the rock, that's right. And in Gibraltar, every day they have the golden hour from 10 to 11 in the morning, and the elderly are encouraged to go out. Others have agreed that they will stay away from the parks
Huh.
that period of time so that the elderly can go there and not be afraid but they still physically distance. And then an hour after that, the supermarkets are dedicated to the elderly. So there are ways of governments facilitating this, but again, everybody must make their own risk assessment and risk decision. And it's very important. You know, if there isn't air conditioning, everybody can afford a fan, and people can live in areas, people have lived with fans for many years before air conditioning ever came into being. And they were able to sleep at night and do what was necessary, you know, to keep themselves cool. So there are ways of doing that. And we can't just say, well, if we don't have an air conditioner, we have to go outside and expose ourselves. That's not the case. There are ways that we can all do based on our own means to protect ourselves and make sure that we're comfortable living during the summer.
So we've got a little less than 10 minutes left, and so I want to shift. We have a bunch of questions focused on the future, and so I want to start to shift in that direction. And the first one asks about the flu season, which, you know, it feels like it just ended, but, you know, we're on you know, at Perry World House, we're in week 10 of remote work. And so just as flu season was starting to end is when we went into this remote situation. You know, now it's Memorial Day, and so any thoughts, you know, based on your career and experience about what preparations for next year's flu vaccine are looking like, and how that may interact, how planning for that vaccine testing may interact with the you know, enormous effort and resources being devoted to coronavirus?
Well, you know, first of all, it's true, the flu season is over and the common cold season is over in the Northern Hemisphere. And people are hoping that this virus also will decrease in transmission in the summer months when it's hot and humid. Singapore has not been able to really control outbreaks, and Singapore is hot and humid all year, much hotter and more humid than Philadelphia in the summer.
Right.
And so it's not been able to control outbreaks which have occurred in their migrant worker populations. It's working hard to do that, but it's transmitting very healthily in that population. Vietnam was able to contain and control, and so some countries with hot and humid climates have controlled, others haven't. It would be nice to be able to say that this will decrease transmission in the summer and we can just go out and have fun. We just don't know. And we don't know whether it will come back in the autumn, in the fall or not. We just don't know the destiny of this vaccine at present, of this virus at present.
So the next question, sort of pointing toward the future, is about the reputation of the World Health Organization. And the question wonders whether the World Health Organization sort of took a hit when it arguably declared swine flu pandemic too early, and then maybe has been seen, rightly or wrongly, you know, to your point, like has been seen as too slow on coronavirus. So
yeah, you know,
yeah.
Go ahead.
What can the World Health Organization do to, in some ways, recover maybe from a reputational perspective and rebuild some of that trust?
The World Health Organization has 194 stockholders in their 194 member countries. WHO is WHO, and it's 194 member countries. They're meeting today in Geneva by Zoom, same as we are, and they'll be meeting tomorrow, and they'll be discussing these issues. And they'll come to some conclusions as to whether or not WHO is the best place in town or not. And those countries will have to develop a consensus based on long and hard discussion, and they will make a decision what they want to do with the World Health Organization. Remember, it's not just an independent group sitting there making recommendations. It's 194 member countries, and those countries have to decide on its future, and they will be doing that. They'll likely call at some point in time for some external assessment of what went on. Not now, hopefully, because now's not the time. We need to finish with this pandemic, but then they'll make their decisions based on that. So, you know, it's not an organization, it's 194 member countries working together, facilitated by WHO Secretary.
So what's your sense then? All right, so I've got two more questions for you. The first is, what's your sense of what are your lessons learned in some ways for for pandemic preparation. If you had the ear of the U.S. government and you were going to give them advice, not about this pandemic, but about what lessons learned for preparing for future pandemics might look like.
Well,
what sort of recommendations would you have?
Well, I would suggest to the US government that they continue to have the various scenarios and exercises that they've had, that we're giving them lessons on preparedness, and that they then follow those lessons, whatever they are. And as I understand it, many countries have had those scenarios, those simulation exercises, and they've made recommendations. And many times they didn't follow all the recommendations that came from them, either because they got caught off guard before they had the chance to make those provisions, or they just ignored the recommendations that came out of their simulation exercises. So I would say they just need to continue along that pathway. When they get recommendations that fit their country context, they should then assess them and implement them.
So the last question is something I've asked everybody that's been on in our virtual event series, which is, in some ways an extended version of Tell Me Something Good. And by that I mean broadly, tell us a story where, despite the horrible trajectory that this disease has had, the enormous human and economic toll that it's taken, where we look back in a couple of years and we say, that was horrible, but could have been a lot worse. And let me give you a little more context for that. And that, one could argue in theory that more human resources are being put against trying to come up with treatments, a vaccine, a response than we've ever placed against, this quickly against any virus in history. And humans tend to figure stuff out eventually. So are there any causes for optimism here, or even more broadly, tell us a story where we look back and say that could have been a lot worse?
Yeah, well, I think the first thing is the rapidity with which we've been able to understand this virus and its epidemiology and its manifestations in human populations. Been a rapid learning of that, very rapid. Think back to HIV, how long it took to understand that virus. Now we understand this virus very, very rapidly. Everybody's been working together. Nobody's been saying, I discovered this, you didn't. It's not mine, it's not yours, it's mine. So there's a global coalition working together to understand this virus and its epidemiology. And also, as you said, there's an incredible amount of research and development going on in new medicines and vaccines. And what that is doing is working more closely with regulatory agencies to be sure that there are streamlined procedures that can get an effective product into human use very rapidly. And so I think when we look back, we will see that this outbreak really did help us improve the way we regulate and are doing our research and development. There are new coalitions that are set up. There is a European coalition working to provide funding for research in vaccines and in medicines, a whole series of things that are developing. And my only hope is that the US will also join in on these as well and provide its expertise globally. And to be honest, they are doing that through NIH and through other groups. And hopefully that work will become even closer.
Well, I've been talking with Dr. David Heymann, a global public health expert, former senior leader at the World Health Organization, who's been helping us understand the world of global public health. And I hope all of you will join us in just 2 days for our follow-up conversation with Dr. Zeke Emanuel, the Vice Provost of Global Initiatives at Penn, and also a public health expert. That's an event co-sponsored with the German Marshall Fund. And we hope you all tune in for that as well. David, thank you so much for sharing your expertise and insights with us. So we really appreciate it. I've learned a lot, and the hundreds of people who tuned in today, I suspect, have learned a lot as well.
Thanks, Michael. Thanks very much. Pleasure being with you.
Have a great day, everybody. Stay safe.